Hello everyone. Welcome to Ankura's EduTalk, where we discuss about essential topics for child health. I'm Dr. Namita from Ankura Hospital, Banjara Hills, consultant pediatrician. Today we will be discussing about digestive wellness in children, an area where we will be discussing about gut health as well as any digestive elements which children suffer with. This will also show you how a pediatrician and a specialist gastroenterologist work together to give the best care to the child. Here I have Dr. Parijat with me, a consultant gastroenterologist who would be joining the discussion. Let's welcome Dr. Parijat here.
Hi, I'm Dr. Parijat and I'm thrilled to be here and we can discuss like how a pediatrician and a pediatric gastroenterologist comes together in giving the optimum care for the digestive health and the I will say not only digestive, it's a lot of things like digestive and liver related problems and all. And let's see how it goes and we can tell our audience that how a pediatric and specialist works together in all this.
Dr. Parijat, usually as a general pediatrician, we are the first contact with the patients and the families regarding their concerns. So we see a lot of spectrum of disorders, including starting from stomach aches to the very severe liver or pancreas disorders also. So what is your perspective about how to go about referring a patient, because it's very crucial to identify which are the patients who need referral and which can be treated as a general outpatient by a pediatrician itself. So would you be able to share your perspective?
Yeah. So what I feel the role of primary pediatrician is the most important and crucial. Like we say, a kid is getting cough and cold since early childhood and they come to a pediatrician all the time where they have a reputation or I will say a faith over their primary pediatrician. So it is always becomes a responsibility of the primary pediatricians to find the red flag in them. Any of the times when parents are too much worried and you feel there are no red flags and otherwise child is fine, you can reassure them. So what I feel the primary pediatrician role is very important in two ways. First, as I said, if some serious disease is underlying, which probably symptoms are not very much overt, so it becomes responsibility of primary pediatrician to find the subtle signs, like in a simple cases like acute diarrhea when parents are feeling okay, some mild diarrhea, but you may find dehydration or something like that. Many of the times child who is not eating well and parents are feeling that he is just being a bit cranky, but you may find no, there is anemia in the child or there are some other signs. So the red flags which you detect at earliest, it is a very important for early diagnosis. And second thing, as we are seeing with the changing lifestyle, with the changing food, so much of screen time and all, functional disorders are so many where parents are excessively worried about the minor symptoms of the kids. So at that time again it becomes very important for the primary pediatrician to find, are there really any red flags or just this is something that which can be treated on the OP basis or reassurance. And again I will say, once the patient comes after a referral to us and then again I send you back, the coordination between the specialist and pediatrician is very important, because always the patients feel very comfortable with their primary pediatrician where child was going for years and all. So referral also and sending you back and keeping a very good coordination between the specialist and pediatrician, what I feel is very important.
That is very true, Dr. Parijat, because the patients have built up a rapport with their pediatrician, but definitely we need to give them extra care which is offered by a specialist. So we have to club both of them together to give the best care to the children.
Absolutely right.
Now let's walk the listeners with some examples of how a pediatrician and specialist work together. We can discuss a few cases and that will make them know how we go about it. So
I'll just talk about one of the cases that we have managed here. A constipation patient. Constipation, as we all know now, out of 130-40 kids are suffering from some grade of constipation these days. Some are very severe, some are mild, some start too early, some start late. So as a pediatrician and gastroenterologist also, we are seeing so many of these patients. So one of this patient where and most of the times it is habitual, what we call functional constipation. So one of these patient which was I think probably seen by you only, so where constipation was very prolonged, not responding to laxatives and all, but the only catch was that the constipation started too early in life. I think parents were telling that initial first or second month only they felt that child was not passing stool regularly. And when you referred the patient to me, when we have worked up the kid and on the general examination, something per rectal examination and all x-rays and some investigations, we have found probably it can be a Hirschsprung disease, which is a surgical problem. It's very rare cause of constipation as compared to functional constipation, but the diagnosis is very difficult. So there are some clinical clues, some investigations which help us in detect, and finally we could make diagnosis of Hirschsprung disease. Child underwent a surgery, and finally he is doing so well. So if we lose these cases or keep on treating them like functional constipation, then the quality of life of the child will be very bad. So this is one very important case, I will say, that we have seen, and it's a very common scenario also that we see.
And this case typically illustrates how a multidisciplinary team
Yes.
works together and
Yes.
helps a child.
Yes.
Timely referral plus a specialist care if
Yes.
necessary, even the surgeon pitches in and we can give the best possible
True,
care for
true.
the child.
So like this child, whenever he comes in follow-up, we are all sitting here, our pediatric surgeon, me and you, every time we can see and we can assess that growth is good, any other factors that child is facing other than the surgical issues. So that is very important for a child to improve, I think. So I think the another important case that I will discuss is a jaundice. What we see, like we are talking about small babies, so I will just tell about jaundice in a small babies. It's so common. Like we always say, like you must be seeing in your practice that so many newborns coming with the jaundice, where jaundice is not improving. We tell, okay, bilirubin has improved from 15 to 10 and 8, and now you can go home. And they come back again after a week or two, that now bilirubin is again 15, 16. What can be the reason? So most of the time we think it can be common causes like breast milk jaundice and some infection maybe. But something very important that we have seen recently, like we see it very commonly, I will say, but for our listeners, I will tell one of the case which we have seen, where parents were telling, okay, jaundice is there, otherwise baby is very healthy, extremely healthy baby. And that is the problem. What happens when baby is very healthy, we may miss the disease, because when baby is not doing well, we will be proactive in doing the tests. But in this baby, when baby was doing so well, when baby came to me, because the jaundice was not improving and baby was referred to me, that is there something else are we missing? Stool color was absolutely white in the baby. Urine was very yellow. What mother was telling, whenever she is removing the diaper, it's like turmeric is there on the diaper. It was so yellow. That means we are not dealing with the normal jaundice. It is some liver related jaundice, what we call neonatal cholestasis. So when we examined and investigated, like so many things are there, we did liver biopsy, we did some basic blood tests, and we finally diagnosed that baby was having biliary atresia. Again, a surgical problem. This is one of the common surgical problem in jaundice in the babies. There are so many hundreds of more diseases where some grades of tests are required so that we can diagnose early. So in this baby, fortunately, we could diagnose within 40 days. Baby underwent Kasai surgery, and fortunately, he's doing well. Again, the role of pediatric surgeon comes in when but these babies typically, what we call biliary atresia babies, are missed on diagnosis for a very long time. Most of these babies are coming to me at 90 days, 110 days, 150 days, when liver is already cirrhotic, it is not working anymore. So what the message I will try to give to the listeners, anytime if jaundice is not improving beyond 14 days, at least go to your pediatrician. Insist them, just let's have a look at my baby. Maybe they can examine. You can do a basic liver function test. Probably we can get some clues rather than missing these babies for a longer time. And whenever you feel like, pediatricians always send or discuss, and then we send back, and we can diagnose and manage these babies early. So that is something very important for all the listeners to understand.
Yes, very important, and it's equally important to observe the stool color of the baby.
Yes.
Because here so many times we see the stool is always mixed with the urine.
Yes.
And parents never know what is the truly normal stool color, which should be golden yellow.
True.
Even many times we see pale yellow, which is considered as a normal stool, and
Yes.
it just carries on.
Yes.
And then we miss the early time where we should intervene.
True. Absolutely right. And now like we have talked about small babies like constipation and this jaundice. Now, third very important thing I will talk, which a topic which is very close to me because I'm seeing a rapid rise in these kids. So, like sometimes what we see in adolescent kids or any child, what happens? Like he doesn't want to play. Like I will tell generally for all the listeners to understand, like any of these kind of kids you are seeing around, like child is not playing, he keeps on, he wants to sit in the home only, he is not as active as his siblings, he is not eating well. So what we feel, and as a pediatrician these kids come very commonly to our primarily to the pediatrician, that my child is not eating well, he is not growing well, he is not interested in anything. Most of the time we dismiss these things as functional problems.
That's because children never complain that they're really feeling tired or they're weak.
True.
They just kind of cut down their activities or do some activities in preference to other, but they will not say I'm not feeling well forthcomingly, which adults are able to tell.
Yeah, that's what. If a child is facing a problem since long time, he will change his nature accordingly.
Yes,
He will not tell I'm having this problem like we do for small things also we will complain a lot. So that is what these kids, like we see very commonly, like a pediatrician sees these kids and you try some things, increase diet, you tell to decrease screen time, maybe this child is too much into screen and all that. I don't want to decrease the severity of this problem, the screen problem which kids are facing these days, and they have become addicted to it. But definitely we need to find those kids which are not probably habitually addicted, but their body is not allowing them to participate in the physical activity, they are not having the hunger. So one of these kids, so we have so many kids, but one of these kids I will tell who came to me in my OPD with the same complaints like our one of our pediatricians sent from far off, that sir, I'm seeing this kid for last 6 months and he's not showing any improvement. I think you have a look, I don't know if there is any gastro issues maybe, because some blood tests are not looking fine to me. So when the kid entered into my room, one child was 11-year-old, this boy was, and the other kid who came to me, they both were of same height. So I asked what is the age of the other kid who is not the primary patient. They said this is 7-year-old kid. 7-year girl and 11-year boy were looking exactly same height. Even the 7-year-old kid was looking more chubby, more active, more enthusiastic in the environment, and the 11-year boy was quite dull and all. And parents were like all complaining that he's like this, he's not active, he's not doing and all that. So when I examined the child, definitely we know this is not something, okay, the growth failure is happening, child is not growing well. By choice, we can't stop our growth. So there is something we need to look into, and this is the clue to all the parents also. If they are really feeling this kind of thing is prolonged, at least meet your pediatrician. Don't all the time say that he's not doing, he's not that. At least rule out the problems. If they are not there, then diet and habits we can change all the time. So when I examined the baby, the child, the 11-year boy, it was looking a bit of pallor. He was anemic, blood was less. His nails were not spoon, they were like beak-shaped nails were there. And it all was giving a clue towards something, a very bad disease called as inflammatory bowel disease. If you treat timely, you diagnose and treat timely, you will have a very good quality of life. But if you delay, then the child will keep on suffering. Like this poor kid has suffered for 4 years. This disease was definitely there for so many years, that which halted his growth. So we see so many kids who are not growing well and all. So we need to look at the minor things. And then we investigated and found that it was Crohn's disease. So it is unfortunate that he had to suffer for so many years. And the symptoms are like, which are very prevalent. What I feel every day, maybe I am also missing so many kids who came to me first, like I felt Crohn's. I could not prove it. It took me 6 months to 1 year because it's such a confusing diagnosis, mimics so many other diseases. So we confuse it. But the important thing is to start suspecting, diagnose them early. So once we started the treatment, now the boy is growing very well. He acquired his maturity also, and now he's doing so well, physical activity, doing well in the class. So it's not like just we are missing the diagnosis. It's like missing so many years of life for that kid. So this is something very important, I feel, and why it happens we don't know, with the changing lifestyle, with diet, and it is increasing so much in Indian children. So this is something where role of a pediatrician and pediatric gastroenterologist is very important, that we suspect early, diagnose early, start treatment early, and take care of the kid because they have, as we say, they have a full life to live. It's not like 5 years they have to live. They are not like old people, whole 70, 80 years they have to live. So all these things become very important, I think, where our coordination becomes very important in these diagnosis.
Yes, because all of the diseases really do not come with red flag signs early in the course.
True.
They may start with just common symptoms like
Yes.
diarrhea, constipation, abdominal pain. But when it is persistent, when the severity is more, and very, very important clue as pediatricians we know is stagnant weight
Yes.
or weight loss or child not growing,
True.
which is important. That's why follow up with a pediatrician over a period of time with growth monitoring, as well as we should not miss the pallor, anemia. So
Yes.
all that makes important thing here.
And many of the times when I'm seeing the kid first time, I may also confuse it like a functional disorder. But when you look at the notes of the primary pediatrician, how so many times they have met one problem which persisted always despite doing everything. Then you get some red flags. No, something is not right. Probably I have to go to next step, because we are always scared as a parent to get new tests in our kids. We don't want to do, but when it is required, it has to be done.
Yes.
That is the issue.
And even if it is a functional one, when it's going on for too long,
Yes.
we need help from a specialist there also.
Right,
because even
true.
that also plays a very crucial
Yes.
role for overall health and the productivity of a child.
Something what we call, like you must be seeing, I am seeing so many patients with pain abdomen. So they keep on complaining pain abdomen, and it keeps on going for months and years. And what parents do? They will change the diet, stop this, start this, try 100 kind of things, 100 kind of restrictions. Many of the times it is simple functional pain abdomen out of 180% of the kids. I think when some common problem is persisting for a very long time, they should definitely consult their pediatrician and pediatric gastroenterologist just to rule out the disease. If there is no need, try to bring him to the normal life. Maybe child has become hypersensitive or some other causes there. And most of the times what we see, kids are not lying. They don't lie. They perceive the symptom as something different. Like one example I always give to my patients. Like our sensitivity levels are quite different. If you slap one person, he may start crying. You may slap one person, he may abuse and run away. So it's not like first person was slapped hard. It's just like their reaction was different. So all the kids have different reaction. Like a small baby who is running, who just started learning to walk. He falls on the floor, you catch him up. Oh, what happened? Next time he will cry a lot. One baby who falls, you say, oh, nothing happened, get up, come, let's play. Next time he falls, he will not react like that. So our reactions decide how our kid is going to react. So that is how in these situations when we are nuclear families, too much attention, not challenging our kids, so they become very sensitive to small things and they react too much to smaller symptoms. And we end up getting so many tests, so many things, and to know that what kind of problem is going on. And from there probably originates our functional pain abdomen. So that becomes very important for the parents to understand first. Because of course, as a doctor, as a parent, we are always scared that are we missing some serious problem. Yes. Of course, we have to rule them out. We have to get some basic tests, maybe sometimes some other tests, invasive tests also. But we need to, once we rule it out, bring child back to their normal thing so that he doesn't carry all these things into his adolescence and adulthood. Oh. So that is also very important, I think.
One more thing we'll discuss as we are already on the discussion. What is the role of diet here? Is there any role of eliminating a few food substances from the diet, which we very routinely see, avoiding citrus, avoiding milk, avoiding wheat? Does it have any role in functional pain abdomen or even children who tend to have gastritis or diarrhea?
So what I feel, first of all, we need to make the proper diagnosis. What are we dealing with? Are we dealing with functional pain abdomen, which has probably no organic etiology or there is no disease? Or are we really dealing with some acidity kind of problems? Or we are dealing with some other organic etiology which we are missing? If after doing everything we think it is functional pain abdomen, I don't see too much role of any diet change. Just what child is doing wrong, you need to change that. If he is eating a lot of junk, you have to keep on adding fiber. You have to remove the junk. You give more of home cooked food. Remove the cold drink, soft drink, soda, all these things. The right thing you start doing, rather than removing the normal component of our daily food, that you stop this also, stop wheat also, stop citrus also. It doesn't make any difference, and it will affect the nutrition of the kid, mood of the kid. If he is liking, sometimes once in a while he wants to eat something like any home cooked nice thing, and you are saying no, it will cause your tummy ache, it's not good for the kid, I think. So once we are very sure it is functional pain abdomen, parents need to understand, and specialist, pediatrician and parents should be on the same page. And over the time, kid will also understand I'm not suffering with something bad. So that this takes a bit of time, but we have to come on to that. Now, second thing, you said citrus food. I always listen that child is having gas. Gas is a very fascinating word in our society. Everything is gas,
Yes.
which goes in the head, which goes in the leg, and it causes all kind of symptoms in the world. So we need to remove this gas word, whatever it is. So we need to find if there is acidity problem, child is having difficulty in eating and all. And then if gas, they are saying a child is passing a lot of flatus, is it their constipation or he is not evacuating his bowel? In those cases, maybe high fiber diet may be required. You need to remove the, you may need to decrease the milk and some maida kind of food which may not provide any fiber, like in constipation what we normally suggest. When acidity kind of problems, rather than citrus food, I will say you need to make some well-known dietary changes, like in the night don't give heavy food, avoid too much of oily food, eat small and frequent food, rather than stopping milk empirically. Stopping milk sometimes helps when we feel there are symptoms of lactose intolerance. As we all know, when we are born, we are quite tolerant to lactose. As we grow, our lactose tolerance may decrease. So, whatever lactose we take, and we have a habit of drinking a lot of milk and taking dairy products. So, some select people may have lactose intolerance. But if they are having really abdominal distension, too much of gas, and with watery stools and all, then we can think of decreasing the milk. Otherwise, empirically, stopping all this will affect badly nutrition of the kid. That's what I feel. So make, and if you find a specific diagnosis like celiac disease, you have to stop wheat and wheat products. If child is having milk protein allergy, you have to stop milk and milk protein. That is a separate segment. But overall, just stopping everything and I will say torturing the kid, not giving him his favorite food, it's not going to help him. Yeah.
So the take home here for the listeners would be avoid junk as much as possible,
Yes.
avoid fried and oily food.
Yes.
Frequently plan your meals the way it suits your child,
Yes.
rather than avoiding all the nutrients or
Yes.
blindly eliminating wheat or
True.
Milk. That could be done only by advice from a
Yes.
specialist.
True, true. And one important thing I always tell to my parents, you say now you will never get French fries and all. He will, that will bring a lot of craving.
Yes.
Next time he's going to a birthday party, he's going to eat a lot because he's not going to get it at home. So I say make a pact. Every 2 weeks I will give you myself, so that his he's getting also, he's not feeling that I am being deprived, and it is under your control. You may cook and give rather than getting it from anywhere which you don't know what is the quality, what kind of oil they are using, how many times that same oil was used for the frying and all. So you give to the kid, he is also happy, but you same time control the quality and quantity also.
Yeah, and you give it with the meals rather
Yes.
than as a sole
True,
meal together.
true, absolutely right. Yes.
Again, one thing, acidity in children is not very well received. Mostly it is called as a gas rather than acidity.
Yes.
Many parents ask, is there really acidity in children also? So do you really see cases with hyperacidity in children, and how do we go about diagnosing it?
Absolutely. So these patients, mostly we have discussed so much about functional pain abdomen. They come like functional pain abdomen many of the time. After eating, he is saying pain. Rest of the things will be normal. Whatever blood tests or scanning, ultrasound, this, that you do, everything will come normal with maybe some mild abnormalities. So what I am seeing these days, there are 2-3 kind of acidity problems that we see. One is reflux problem, where stomach is a normal component of our, acid is a normal component of our body. When you eat food, stomach will give acid to break down our food particles. If this is coming up in our food pipe, then child may feel like what we say heartburn. Many of the times kids are not able to tell that there is heartburn. They will just say I'm having pain after eating food, and we dismiss it as functional pain abdomen. So there can be reflux. Sometimes there are inflammation in the stomach because of some chronic infections or ulcers also. So that can lead to pain after eating food and all, and that may decrease appetite of the kid. So many of the times we do the basic test. If it is normal, we go ahead with endoscopy, and many of the times we find in endoscopies that acid is coming up and there are signs of damage in the food pipe. There is swelling in the stomach. Biopsy may show that there is some bacteria which is very common in the environment in general population, H. pylori bacteria. Probably that is causing inflammation in the stomach, or sometimes we find ulcers also even in kids. So we need to find which one of these three we are dealing with, and the treatment will change accordingly. So that's where I will say a specialists come into. Probably you will looking at the history and you will come to know this is acidity issue.
Right.
But if it is going on for a longer time, not responding to basic medications, probably we chip in and we do endoscopy and we make a final diagnosis and then we treat it. So most of these are improved with the medicine. Some of these diseases I will say a bit prolonged, because if reflux problem is there, no medicine will stop the reflux. As child is growing, maybe our muscles will become strengthened and the acid will stop coming up and child will improve with the time. Meanwhile, we have to give him symptomatic relief.
So acidity can present as pain abdomen, it can
Yes.
present as a reflux, cough,
Yes.
vomitings,
True,
all
true,
of it.
true.
When it is not transient, when it is
Yes.
persisting, we
Yes.
should do further investigations.
Yes.
So Dr. Parijat, we have discussed the cases where there is a need to escalate the treatment from a general pediatrician to a specialist care. So what kind of services do you think they need whenever the patient
Yeah.
comes to you, and how do we offer them?
So most of the time what happens, like always tell to my patients also, that they will say, oh, you diagnosed it so early, our pediatrician could not diagnose. They don't understand that I have the luxury of such a long history. I have the luxury of so many tests which are already done, and so many things which already primary pediatrician has ruled out many of the times. So but what happens at this juncture, they need some specialized tests, of course. There are some blood tests or stool tests which normally we don't prescribe to our kids, because they may be a bit costly, maybe a bit cumbersome, or normally they are a bit rarer diseases. Of course, the patients who come to me are, I will say, will be sieved out from the pediatrician that these patients probably need a specialized care. So then we have to see what specific blood tests they may require, maybe some immunity related tests, some allergy related tests, some specific inflammatory markers. I will not be elaborating that too much because that may create some confusion. Then some specific stool test which tells about the digestion is happening properly or not, or some inflammation is going on in the gut. Depending upon these, maybe we can go ahead next with our imaging things, like we do here quite frequently, like some kind of imaging, a special type of CT scan or MRIs, or sometimes breath test which needs to be done, or manometries which needs to be done to know that what is there any structural problem or any inflammation or swelling is going on inside our intestine, liver, pancreas, all these things. So after blood test, stool test, then comes these our breath test. Then what we do is our imaging, CT scan and MRI that may be required. And then finally, most of the time, our most important tool is endoscopy and colonoscopy, because that is the way that we look into our, like, in last few years we have done more than 1,000 endoscopies and colonoscopies, starting from 800-gram kid till 80 kg of kid, like the kids we are seeing. So whenever it is required, it has to be done. The problem what happens is, the moment you tell parents your child needs endoscopy and colonoscopy, they get very scared.
Yes,
So
I have recently seen a patient who had got almost 8 ultrasounds done
yeah,
with each pain abdomen episode
yes,
or each vomiting.
okay,
But the moment we said endoscopy, they were really worried.
yeah.
How can we do endoscopy in a child was
Yes,
their
true, true,
question.
true, true. So once we go through, of course, if someone tells ki your child needs endoscopy, even as a father, I will also get worried why he needs endoscopy, why you need to do all these things. So that is what first these things, and endoscopy, colonoscopy we do, and that is mostly in liver problems. We may need to do liver biopsy, and all these things we are doing here very frequently and in house with the support of our multidisciplinary team, radiologist, and all of us. So I will just elaborate on it, this endoscopy colonoscopy thing, basically because this is such this many of the parents, what happens that, oh, my grandfather underwent endoscopy and it was so painful, we were so scared, and we can't let our child go through all that. So what I will say, first of all, Of course, it is not a routine test. It should not be just be done ki, okay, your child is having pain abdomen, let's do endoscopy, let's do colonoscopy. Absolutely no. If child's disease earned it, that means it is severe enough or it is prolonged enough that we are really suspecting something needs to be ruled out or something needs to be diagnosed. So we have to do endoscopy and colonoscopy. So parents must know that really this test is required in my child. Second, their pediatric gastroenterologist must tell them that what are we expecting. It's not like, okay, I have done, it's normal, now no go, what is this? No. So because it's a small child, so we need to be very clear. If normal comes, what are we thinking? If abnormal comes, what are we thinking? Of course, then there are surprises that we can tell only after the report is there. So we need to know what action are we going to take after that. What diseases are we suspecting where endoscopy and colonoscopy will really help. It's not something like we did ultrasound and it's normal and you go. It's an invasive test, as we said. So we do the test, we know the proper indication, what are we doing. When we get any findings, what are the possibilities we are going to treat. If any surprises is there, of course, your doctor, if he is experienced one, he should be able to tell you that what next we should go ahead. So whenever we do endoscopy and colonoscopy in kid, most importantly, I always feel it should be done under mild anesthesia, mild sedation, so that child does not feel any pain. So parents tell, no, 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 we got it done without anesthesia. So what do you think? Your child should underwent, someone is holding head and leg and someone is pushing a tube in the child's mouth. I will say it will be not that painful, but it's a very scary experience for a child. In this age, I don't think when medical field has advanced so much, I don't think our kids should suffer through endoscopy and colonoscopy. So they should be given some mild sedation so that they are comfortable. They don't even know what has happened. And the procedure, endoscopy should finish in 15 to 20 minutes. Some complicated things being done may take a bit longer time. Colonoscopy maximum 1 hour, and depending upon the complexity of procedure, sometimes even it can finish in 20 minutes also. So sedation has to be given, proper preparation has to be done, and child should be pain free and comfortable during the procedure. And most of the time, if child doesn't have any memory of the procedure, next time he may come back and he will be more compliant to the treatment. If he understand, no, no, these doctors and my parents took me to such a bad procedure, later treating him will become difficult. So he should be on the same page, but we don't need to tell them absolutely everything. That's why the age cutoff is there. Of course, when a child is more than 12, I always discuss with them that this may happen, what you feel about it, are you having any fears about it. Clearly discuss with me. I will tell you what are you going to face. If you have any fear, you don't want to get it done, tell me clearly like a friend. So those kind of comfort should be there. It is not like that what happens most often, ma'am, what we see that symptoms will be there. If like you are suspecting this disease is there, parents will go search, of course, on AI and Google and all, 8-10 diseases they will come to know which are really bad. I am not saying your child is not suffering with them, he may be suffering, but overthinking doesn't solve anything.
Right.
We need to find, of course, your child is not suffering from all those 8-10 diseases, he's suffering from one of them most likely. We find it, treat it. Why to think so much, create so much chaos, to put scare in the kid's mind also, that because this is his growing years. If we make him scared with everything, what kind of personality he will grow with. So that becomes very important. Keeping the kid, the primary patient, comfortable is the most important priority. Anytime as a doctor we feel we have to cross line, like this procedure can be a bit risky or dangerous, if it can be avoidable, we mostly avoid it. But if we feel no, no, it is very important for the kid, like sometimes tumors in the intestine, we have to cut and remove it because child is bleeding from there. We need to discuss with the parents what are the risks, what are not the risks. Even if problem happens, what we need to do. All this should be clear and we should go ahead with all the investigation. So this part is very important to understand for the parents, to bust the myths. And I will say, rather than myth, I will say the fear is real. But don't be unrealistic about the procedures. If it is not required, better you discuss, don't get it done. If it is required, don't delay it. Get the diagnosis, get your child treated and get out of this disease process and all. So I think these are the important tests and investigations, and specifically our invasive tests and all that are required. And of course we do it all the things. And Right now we have seen roughly 10,000 kids in last few years. We have done more than 1,000 endoscopies. So touchwood, all are doing well, and so safety of the kid, as we said, is the most important factor when we are going ahead.